I'm getting my bearings. Arrow this way, arrow that way. I'm good. All right, first of all, I was really honored to be asked to be a part of this workshop and symposium, and want to thank NIAAA for funding it, and for Tammy and Sara for really pulling it all together and for having the guts to try to go get it. So thank you very much. So this afternoon, in my time, I want to kind of take us back to take us forward, I think, is sort of how we need to think about this. Because when I asked Sara and Tammy, what is it that you really want me to cover? They sent me a single-spaced, one-page filled thing. And I went, wow.
Sara Joe.
Okay. So I dutifully addressed all of those things. I had about 60 slides, and I sent it back to them. And they said, oh, not really. We weren't that serious about that. All right, so I'm going to I want us to review really a lot of what we've talked about this morning, but in a slightly different context. So, and a pointer, this is it? Okay, good. So, what do we know? Well, basically we know alcohol is bad for your brain. That would pretty much summarize most of what we know about the brain, but in what particular ways, and does that really matter? And that's where I want us to get to in the next 20 minutes. First of all, we know that alcohol affects the structure of the brain. This is now a very old picture that Dolph Pfefferbaum had and has forwarded, and we used it on the front of a book that we wrote in 1993 called Alcohol-Induced Brain Damage. So we've known for quite a while that alcohol is bad for the structure of the brain. We also know that not all areas of the brain are equally affected, and that of particular import are the prefrontal areas, but also the parietal occipital areas and the anterior temporal areas. But the other thing I want you to notice about this slide has to do with a subject characteristic, and that is age. So when we start thinking about the effects of alcohol on brain and function, and we talk about individualizing things, and we talk about factors that can affect that individualization, we have to start thinking about younger versus older, or age as well, right? Now, we've talked a lot about DTI, this is another publication out of one of their publications of Dolph and Edie's, where they've looked at white matter integrity, and they've done so in 3 different ways. And they've also looked at sex differences. So if you look down here, here's the fractional anisotropy measures, and the open ones are for the alcoholics, the closed one for the controls. And if you look across, you see that the FA scores are indeed lower for the alcoholics as opposed to the controls for all but the sensory motor. But you also notice something else. There's a lot of variability, right? If you look at other measures of white matter integrity, in particular the measure of radial diffusivity or the longitudinal diffusivity, you see slightly different kinds of patterns. So in the radial one, you see that they are different on all. The alcoholics versus the controls have greater diffusivity on all across all these brain areas. Not so on the longitudinal ones. Now, why is that important? Because this measure, the radial measure, is supposed to be more sensitive to the myelinization issues, whereas this one is supposed to be more sensitive to axonal issues. But they all talk about white matter. So what? So we have 3 measures of white matter integrity and slightly different patterns depending on which one we want to look at. Furthermore, we've often thought that women are more susceptible or more vulnerable to the negative effects of alcohol. And yet this study showed that there were no differences between men and women, okay, as a result of their alcoholism. So it failed to support the idea of a female vulnerability to alcohol's effects. All right, So we've got the broad structural ones with structural MRI, we have DTI, and of course we have fMRI. And this is a slide that, that Marlene sent me, in which she she's outlined this in a couple of different places, but it's done well in a review that she did in 2007, where she talks about the fact that, you have certain kinds of activation patterns in alcoholics versus controls, and sometimes the activation for alcoholics is actually greater than it is for controls. So the idea of a hypoactivation pattern doesn't hold across all domains. And she said, if you put all this together, what happens? What do these shifts really mean? And she proposes that the likely outcome of a shift in the functional anatomy in an fMRI is that a person's responses can appear normal. So as an average, overall, what does it look like? But she believes that that's at some cost. And that is at the cost of using the brain's reserve, thereby reducing the person's overall efficiency, especially when multitasking. So now we begin talking about process. So when we talk about alcohol and brain, we talk about these different patterns. We are often saying this group is different than that group, but without real attention to the fact that this is really maybe reflecting a difference in the activation and use of reserve potential. It's a thing that we've indeed called cognitive inefficiency. All right. Brain structure, DTI, fMRI. We talked briefly this morning, there was mention made of, electrophysiology and EEG and ERPs. And ERPs, as you all know, are a nice way to look at temporal processing. Imaging thus far has been really good with spatial. Maybe we can bring them together. More and more we're trying to do that sort of thing. But in general, we get a tighter temporal resolution with the use of electrophysiology. It's also cheap. It's also non-invasive. It also hardly ever gets used by somebody else, so in the lab. So you're good there. All right, now, this is a very old slide. Why do we keep using it? Well, because it shows very nicely the contrast in what you can do. So if you're looking at a P3 and you're using a very simple oddball task where you have red and green dots, and your red dots are occurring only 25% of the time, and you're just supposed to count them in your head, what happens if you're our control? We see that about 300 milliseconds after the presentation of this novel but meaningful stimulus, you see a positive shift in the underlying brain electrophysiology. And what do we see with detoxified alcoholics? That the difference between the relevant and the irrelevant is not obvious at this level of analysis. It's consistent with the idea that they're not dealing appropriately with irrelevant information. We did some work because we weren't interested in dots per se, although I am when I see dots. I'm very interested in dots. But we were interested more in other cortical functions like language. So we used the N400 or semantic incongruity task, where it says the pizza was too hot to whatever. And this slide was made by a real electrophysiologist. That means negative is up. We who do cognition would never, of course, graph it in that way. All right, so negative is up. The pizza was too hot too. And indeed, if it's eat, okay, big deal. If it's drink, it didn't make sense, but okay. But what if you put in the word cry, right? Cry makes no sense unless you are a 2-year-old, right? And the pizza was too hot to cry. What happens? There's a negative shift at about 400 milliseconds afterwards. And we had the hypothesis that if indeed this deficit that we see in alcoholics was due to this inability to deal appropriately with irrelevant information, what should happen with this task? And the idea was that alcoholics should not show this N400 to the same extent. Not that they wouldn't show it at all, but that controls. And we were fortunate, or I probably wouldn't be using this slide, to find, indeed, if you look across sites, these are difference waveforms, but just look at this one. Here's the controls at about 400 milliseconds. You see this negative shift saying that made no sense to me, right? If you look at the alcoholics, this shift, if you base it on the window, you see very little. There does seem to be something else going on out here, and it resolves differently. So the pattern is different for the alcoholics as opposed to the controls. And this study, there are men and women, both. They're all treatment seekers, and they all have at least 21 days sober. And they're on no other psychoactive medications, and have no other significant psychiatric disorders. So it took a long time to collect these data, right? Absolutely, it took a long time. Why do I bring that up? We talk a lot about all the confounds, all the other things that happen in an alcoholic's life, and we should talk about those things. But even when we are able to identify and use a sample that is clean of those things, we see shifts in the underlying neurophysiology. It isn't just about all these other things, although no doubt these other things create all kinds of complications. Now, recently, there's been a lot of attention paid to the idea of, can we use brain electrophysiology in a different way so that we can improve sensitivity and specificity in understanding what's going on in the brain's functional activity at any point in time. And so there's been an attempt to link ERP studies here, for instance, where you would be looking at N100s to P2s, N2s, and P300s. This positioning is really kind of awkward. And then building into that the idea of looking at shifts in the underlying electrical activity that seem to drive these event-related potentials, but allow us to look at the power of these segments, these frequencies within those areas. And this particular approach will allow us a better understanding of what drives these event-related potentials, but also when we don't see differences here, do we see compensatory activity across the alphas and thetas and betas and deltas and gammas that we may be interested in looking at. So it requires a different approach to data that we're already collecting, and maybe a way to address some of the issues that we talked about in terms of sort of challenges to being able to use imaging in some cases, allow us the other option. And I think, all right. Now, that's all well and good. Notice that I started with structure, went to fMRI, now to EEG, and now, so lots of what the questions we're asking about the effects of alcohol on the brain, a lot of them came from the neuropsych literature. Decades ago, people began to say, hey, as we learn more about the brain and the areas of the brain that seem to be responsible for what are the areas that are affected by alcohol and what are the neuropsych domains that are compromised. And you can see that across these various domains, some very important areas of the brain. And guess what? We can determine this with behavioral data. But fortunately, fMRI and other imaging techniques have allowed us a better picture of that and have allowed us to say, hey, this task seems to be sensitive to the effects of alcohol, this task does not. These are the brain areas, and furthermore, the brain connections. When we start talking about the DTI and the neural circuitry and the activation patterns, that may differ. So what are the behavioral? Let's move from the abstract to the what are the behavioral effects of alcohol on brain in chronic alcoholics. And here you see this is a bunch of executive, short-term memory, upper limb, declarative memory, visual spatial imbalance. These are between controls and alcoholics. And you find that, of course, there are deficits across a number of these. There is a wide, diffuse, generalized dysfunction associated with the chronic use of alcohol. But what these don't show are the fact that alcoholics also experience a great deal of interpersonal problems, difficulty in real-world processes, and altered responses to emotional tasks. Most people do not come to treatment because they don't do well on the Trails B. It's shocking, I know, but they don't, right? Most of them end up in treatment because of these kinds of things, right? They're in trouble with their spouses, with their families, in the workplace. They can't hold a job. They have lots of legal issues, et cetera, et cetera. And hopefully, if we're going to explore, and that's what I do, is explore the effect of alcohol on brain in neurocognitive and neurobehavioral functioning, we began to address some of these issues as well. So, we have a wide array of deficits. You can get them when you use very carefully constructed batteries using very sensitive neuropsych testing, when you do imaging, when you do neurophysiological kinds of measures, when you ask people to rate the emotional expression that they're seeing on a face. Very broad spectrum of problems associated with the chronic use of alcohol. So what? If it just stays that bad, why do we bother with it at all? We know it's bad, that's it. Well, ultimately, we want to be able to talk about recovery and change and improvement over time. So let me ask you, is there recovery? What does it mean when we talk about change and improvement, and are they even the same thing? So, what about your behavioral performance? What about structural recovery? What about, that word is actually not supposed to be patient, it's supposed to be pattern, okay, neural activation patterns. And what about the limitations of cross-sectional versus longitudinal work? Is there real recovery with time? Not with intervention per se, but with quitting drinking. Okay. So, this is a study. These came out of a very old study done by Oz Parsons, in which, over a 14-month period, they tested treatment-seeking alcoholics and controls. Notice that was an important part, was that they tested the controls and retested them. Oftentimes, we just retest the alcoholics, and we see a change, and we call that recovery. Is it recovery or is it practice? And in this study, they reported that indeed, at the first test, the alcoholics were inferior to the controls, that is the yellows versus the line. And at retest, 14 months later, guess what? They improved. If you looked at this effect, you would say they recovered. If you look at the alcoholics versus the controls retest, you would say they got better. In the real world, does it matter? If indeed they improved, do we care if it was a practice effect? I mean, that's not a question that's easily answered, because we want to say, no, it's about recovery, it's not about practice. But if they practice and they get better, it's like playing the oboe, if only I practiced. Okay, never mind, that's a whole other story. All right, now, and Edie and her crew then switched it around a little. They said, wait a minute, let's look at changes in performance based on whether or not individuals abstain or resume drinking. And guess what? What happens? The group that does better is the group that abstains, right? Now, it's important when we start talking about relapsers what that means. And across the larger literature, relapse doesn't mean relapsing to the same level of drinking that they were drinking before they went to treatment. It means resuming some level of drinking, right? So, abstinence is important. This is a very interesting series of slides here. Here we have an individual, they are, God, I wish I could see this. Oh, let's not do that. Oh. Let's try this. Will that work?
Just click on your screen.
Oh, never mind. Oh, that would have been helpful. All right, so here we are. We have an alcoholic woman who's 8 months sober there and 1 year later drinking. Here's a person 7 months sober and 1 year later drinking, right? What do we see here? Here they are a year later abstinent. You see a reduction in the lateral ventricles, a slight reduction in that one in terms of the lateral ventricles, but more importantly, for the 41-year-old, you saw a resolution of the central pontine myelinosis. That's pretty remarkable. Yeah. Now, what about resting state synchrony? We talked a little this morning about looking at various areas of the brain and their activation patterns. The thing here is that this is some of George Fine's data where he divided the brain into appetitive and control networks like we were talking about. And indeed, when he looks at the synchrony of the appetitive drive network, let's look at just these two. The long-term abstinent alcoholics had a decrease in the appetitive drive network, but an increase in the control networks. So it isn't just a change in one, but a change in the balance across these networks. So what do we know? Well, if I had to summarize the entire literature, which I kind of felt like I had to do, you will find that largely the verbal abilities recover. These frequently used verbal abilities, often within the first month. Okay? But as I've shown you, sustained abstinence is critical. And the long-term sober alcoholic studies suggest that the recovery in certain functions happens much easier than it does in others, and that various areas may not recover fully at all. Age is a factor that has to be dealt with, and the role of comorbid drug use, including nicotine, right? Because treatment seekers smoke. A lot of them do. And one of the things is that we need to take into consideration that chronic smoking is also not good for your brain, but acute nicotine might be. So are we testing them when they're smoking, or are they not smoking? Are they in withdrawal? When we retest them, are they smoking, or have they quit smoking as well? All of these impact what it is that we're likely to see. All of these findings showing this broad set of deficits should impact what we're thinking about, right? It should complicate the array of stimuli. It should suggest continuing psychosocial problems. It should. That's what they should be linked to. But what are the outcomes? Predictors of treatment? We talked about this. What is the outcome that you're interested in? Is it staying in treatment? Is it not drinking? What is it? These are not new questions, okay? There have been a host of alcohol scientists who have tried to address this, including some in this very room, who have shown that the link between cognitive impairment and outcome is very complicated. Social support, whether or not self-efficacy, et cetera, and not always in a meaningful way. So, what about interventions? Wait, this is another RSA when it was in Hawaii back in the day. There is some promising work because one of the things is that people have begun to say it's not a brain area, it's a brain system. When you talk about a system, you can talk about processes. When you talk about processes, what is it that seems to be most compromised? And it seems to be working memory and attention. So 2 recent studies have attempted to look at that and to look at some rehabilitation or remediation approaches and have found some promising outcomes. But what do we know? We have a compelling literature describing neurobehavioral compromise after detox. We have a complex picture of how these impact anything. And we have promising, but so far we've not really done a good job at long-term outcomes or looking at the broader picture. Is it really all about alcohol? And we have questions. Would training, does it need to be focused training? Will it generalize to other cognitive abilities? And will it generalize outside the treatment setting? So we've got to define the outcomes. If indeed we're going to link neuroimaging and clinical treatment outcome studies, we have to know what it is we're looking at. We have to have a strong conceptual model and testable hypotheses. We also have to be clear. Are we talking about practice, recovery, compensation? Does it matter? And be clear about that. And is it really all about the alcohol? I wanted to have that all about the base. Right. All right, so are we dealing with interpersonal relationships? That's what drove them into treatment, right? And what about other risky behaviors? And in general, things like behavioral discounting. I want to thank this crew who really had nothing to do with this talk. I'm kidding. All right, Robbie in particular, who helped put together the slides, and I made it.